Greetings to all. I, Priyal Yadav, welcome you all to the Physio TV. Today we are presenting the second part of the topic neuroplasticity in rehabilitation. As we are done with the first part of the same topic, and if you haven't seen it, please go back to the Physio TV channel, watch the session as it will be more clearer and it will be helpful for you for the further session. Thank you. I would like to welcome Dr. Franny Nathani, ma'am, to continue the session for today. We welcome you, ma'am.
Thank you, Priya. Please just let me know if the PPT is visible.
Yes, ma'am, the PPT is visible.
Thank you. So in the previous lecture, we saw the history of neuroplasticity. What exactly is neuroplasticity and what are the various mechanisms how neuroplasticity actually works. So in this session, we are going to see the continuity of it. So we will start with the principles. There are certain principles of neuroplasticity, and followed by that, we will see various approaches and treatment techniques that are based on those principles and the mechanism of neuroplasticity. So starting with the principles. So Clayman Jones in the year 2008 suggested 10 principles that potentially impact the neurorehabilitation practices, of which we start with the, we see one by one each one of it. So we start with the first one, which says use it or lose it. So it says failure to drive specific brain functions can lead to functional degradation. That means if neural circuits that are not actively engaged in certain tasks for a prolonged period of time, they will begin to degrade. They will start losing their functions. In contrast to it, training actually protects those neural circuits and connections that otherwise would have been lost after the lesion or the injury. And that is why the second principle says use it and improve it. We come to the third principle, that is specificity. So the nature of the training experience dictates the nature of plasticity. That means a specific form of plasticity will require a specific form of exercise. Simply repetitions of exercises that do not make any sense to patient or those are not salient would not function, would not really help in neuroplasticity. So it basically has to be activities that are very specific. Moving ahead, repetition matters. So this principle talks about the importance of repetition in neurorehabilitation. So we must have seen the patients suffering from some neurological conditions in their training. They perform a lot many number of repetitions, and that is because of this principle. And it is important because many number of repetitions that actually helps you formulate engrams. So what does engram do? So basically after formulation of engram, you will be able to perform that activity without complete consciousness about that task. So you can say, to actually help the transfer of training to take place, there has to be a lot many number of repetitions for that. So transfer of training, that means if a patient is performing, let's say 50 repetitions of particular activity in the clinic, or let's say sit to stand, 50 repetitions of sit to stand in the clinic, the patient should be able to perform the same activity when he is at home. So this we call as transfer of training, and this requires a lot many number of repetitions. Although it will be patient specific, that will depend on the vary from patient to patient, but it has to follow the overload principle as well. So when I say overload principle, I meant the intensity also matters. That is our fifth principle of neuroplasticity. So whenever we require experience dependent plasticity, it has to, the intensity has to be intense enough to produce this experience dependent plasticity. Now there's one thing about intensity, that it has to be timely modified depending on the skill level that the patient is achieving. It has to be modulated from time to time. It has to be progressed according to the skills achieved by the patient. So for this, I would explain it with one research that was performed in the year 2009. So basically, the research was performed in patients with acute stroke. That is after less than 14 days, between 14 days after stroke. So the patients were divided in 3 groups. The first group was conventional therapy group that received 2 hours of occupational therapy as the conventional treatment. The group B was CIMT group. Now this group received, CIMT is constraint induced movement therapy. So now this group received 8 hours of restraint from the unaffected hand. So the unaffected hand could not be used for some activities, and there was forceful use of the affected hand to perform certain functions. So this was group 2. So there was 8 hours of constraint and 2 hours of task-specific training. The third group was high-intensity conventional therapy, high-intensity CIMT group. So now for this group, 90% of the waking hours, the hand was restrained. And the patient underwent CIMT, that is forceful use of the affected hand training for at least 8 hours per day. And then when the results were seen on all the patients, it was seen that group B and A, that is the conventional therapy group and the CIMT group, they showed significant improvement in their upper extremities function. But the group C, that is high intensity CIMT, the group did not show significant improvement. So why I wanted to speak about this this research was the intensity, the time after the injury, and the repetition has to go hand in hand. So this program is called as vector. So many number of repetitions immediately, that is very early CIMT is not suggested. Moving ahead, the sixth principle is time matters. So different forms of plasticity occur at different times during training. So the training is going to vary from the time to time. That is, the training for the acute phase would vary as compared to the subacute and then the chronic stage. So there was another study that was done in the year 2004. So in this study, the patients were hemiplegic, and there were 2 groups. So for first group, the intervention had started 5 days after the stroke. And for the second group, the intervention started 30 days after stroke. And when the results for both of them were compared, it was shown that the group A, that had started early, showed better improvement as compared to the group B that had started 30 days after the stroke. So it basically tells about the importance of early intervention in the rehabilitation. Moving ahead, it says salience matters. So basically, whatever activity we are making the patient do, it should make some sense to the patient. The patient should be motivated enough to perform that activity. Now, the reason being, when we see the neuroplastic changes or the cortical remapping that takes place following the training, it is more when the neuroplastic changes are furthermore when the patient is motivated to perform that activity. For example, let's consider the therapist wants the patient to perform, let's say, 10 repetitions of elbow flexion. if we want a pediatric population or a pediatric patient to perform this activity, he would not be motivated enough to perform this activity 10 times, right? But if we try to change the activity by making it a task, making this activity a task dependent activity, for example, the child could pick up some food and put it to his mouth. So it may be the child's favorite food, and the child is supposed to pick it up and put it to his mouth. So that activity anyway performs elbow flexion for repeatedly. For example, let's consider a patient with adult patient secondary to stroke. So if you, again, let's consider the same example where you want the patient to perform elbow flexion. So instead of asking the patient to simply perform elbow flexion 10 times, you can maybe train the patient for maybe, let's say, reach to your earring, or if the patient has good control, then maybe you can ask the patient to wear the earring or turn off the earring repeatedly. You can train the patient for that. So basically, whatever makes the patient motivated enough to perform that activity, that should be incorporated in the rehabilitation. Moving ahead, it says age matters. Now, training induced plasticity will be present throughout life. Okay, but there's one thing, that the neuroplasticity in younger brains would be much more as compared to the aging brains. It has been shown that neuroplasticity or training induced plasticity does take place in adult brains also. Okay, the only difference is in aging brains, it would be lesser, at a lesser rate as compared to what it would do in younger population. The ninth principle talks about transference. So basically, plasticity in response to one training experience can enhance the acquisition of similar behaviors. So like we discussed, if we are training the patient for sit to stand, the patient does perform, let's say, 50 sit to stand in the clinic in our presence, but is not able to perform a single repetition or a single time. He is not able to do sit to stand at home. So that means transfer of training is not really taking place. So so the treatment should be such that you actually look that the transfer of training is taking place. So in the absence of the therapist or in some other environment, when the environment is changed, the patient is able to perform the same activity. So those were certain principles of neuroplasticity. I found 4 more principles from the book Umfred Darcy, the Neurological Rehabilitation, 6th edition. And I liked all the 4 additional principles that have been given. The first one is reward or feedback. So we earlier spoke about the knowledge of result and the knowledge of performance, and how feedback pushes one to do certain activity, motivates one to do certain activity. So reward or feedback should be incorporated in training, especially when the activity is being performed correctly. The next principle talks about the environment and the importance of enriching the environment and noticing everything in the environment and trying to utilize various things available in the in the environment. So basically interacting and finding more opportunities and interacting with others and other structures in the environment. The next principle is fun, which says that learning is optimum when it is associated with discovery and fun. So the rate of learning would be much more if the person or the subject is enjoying what activity he is doing. So that's why we said the activity should make some sense to the patient, and the patient should be motivated to do that activity, and at the same time the person should be having fun while performing that activity. And that's how we talk about play therapy in pediatric population or group therapy in adult population. These activities actually help the subjects to do more. So again, we talk about helping others. So maintaining the fitness of the brain is best when individuals look beyond themselves to help and involve others. So that actually can be best fitted in group therapies. So when the person tries to look beyond himself and tries to help others or cooperatively perform some exercise with other population, that helps the neuroplastic changes to occur better. So these were certain principles of neuroplasticity and how these principles should be incorporated during the therapy. We are now going to talk about the various approaches that are based on either the principles or the mechanism of neuroplasticity. So the first technique that we're going to talk about is constraint-induced movement therapy, which is also known as CIMT. So as the name suggests, there will be constraint or immobilization of the unaffected hand. That is, the good hand will be constrained using a hand mitt or a sling. And the affected hand, the affected limb should be used or should be forcefully made to use. So we use the affected limb for engaging in a forced use, a mass practice, but make sure that whatever the patient performs with the affected hand, that should be a task, and that should be a task that patient would like to do. So that means should be salient. So CIMD has been shown effective therapy in persons with various conditions such as chronic stroke, in patients with brain injured, or patients with brain injury, in children with hemiplegic cerebral palsy, patients with Parkinson's disease, and it has also been effective for treatment of lower extremity. So balance and strengthening using lower extremity. So constraint of the affected lower extremity, unaffected lower extremity, and forceful use of the affected lower extremity, especially when the patients do not take adequate weight on the affected lower limb. Now, what are the parameters required for CIMT? So the first one is there should be restraint of the unaffected arm using a mitt, a hand mitt, or a sling or a glove for 90% of the waking hours for a 2 to 3 week period. And the patients concentrate on intense or repetitive task training for almost 8 hours a day using the affected hand. So this is something called as CIMT. We now use modified constraint-induced movement therapy, in which the hand is constrained for only 8 hours and the patient performs 2 hours of activities. We'll talk about the limitations of it and why modified CIMT came into existence. So when it was seen, the improvement of CIMT, it was the various outcome measures that showed the beneficial effects of CIMT were motor activity log, Fugl-Meyer test, Wolf motor function test, and the fine motor improvements, which were measured or assessed using grooved pegboard test and other dexterity tests. And it was seen that the effects of CIMT are long lasting, because in a study when they saw the follow-up evaluations up to 2 years after the training, it showed that the improvement still persisted. So now what is basically the mechanism of CIMT? How does that actually work? So basically, if we see after stroke, so after stroke, there's impairment of the affected hand, and the patient learns to not use the affected upper extremity and rather compensate using the non-affected extremity to complete the task. So now this the learned non-use of the affected extremity that actually produces cortical remapping. So now neuroplasticity can be function enabling and it can be functional disabling as well. For example, if the affected hand is not used, so it will create functional disabling plasticity in that part of the brain that supplies the affected extremity. So now how does CIMT work? So it overcomes the learned non-use and plastic brain reorganization. So it produces use-dependent cortical reorganization in humans with stroke-related paresis. So we will now see certain challenges that one faces while CIMT. So first of all, time and the physical demand on the therapist. So now during CIMT, there has to be therapist to patient ratio of 1:1. So the therapist always has to be with the patient, and it is suggested if the therapist can maintain a diary that maintains the log, a per day log of for how long was the constraint being done and for how long did the patient perform the activities using the affected hand. So that basically increases the cost to the patient and the resources that are required during rehabilitation. So basically the handmade or the sling or the glove required for constraint of the affected hand, that could be one more reason. So many subjects, when they were offered to be to participate in CIMT, they actually refused because of the intense practice schedule and the necessity of the restrictive device. Also, many patients in acute rehabilitation setting, they do not qualify for CIMT, and it can prove to be beneficial. It can prove to be difficult, frustrating, intense, and progress can be slow in certain patients. And that is why modified CIMT came into existence. So this is one study performed in the year 2018 with the aim to see the addition of CIMT to the regular physical therapy program or the conventional therapy. Does it have any effect on cortical activity and on various functional outcome measures for upper extremity? So there were 40 stroke patients which were divided into two equal groups. The first group performed functional training with CIMT along with the conventional therapy, and the second patient performed intensive physical therapy program only. So the outcome measures that were used were Wolf motor function test and quantitative EEG. And in the results, they found that the group A that performed both the CIMT along with intensive physical therapy program, that showed significant improvement in the Wolf motor function test, that is the outcome measures. And also there was a post-treatment improvement in the values of alpha and theta waves seen on quantitative EEG. The next technique that we are going to talk about is the virtual reality. So virtual reality is actually a computer-based technology which actually allows the user to interact with a multi-sensory but a simulated environment, and the patient receives a real-time feedback on the performance. So the software basically has various interactive games. Now these games can be used for the purpose of upper extremity, improving upper extremity function, lower extremity function in patients for or in fact for cognition as well. So it provides real-time scenarios and activities relevant to daily living. In fact, virtual reality these days has become very common because there are certain games that are being used by the people in various malls. I came across certain stores and the people happily play those games, and that's one reason, because that actually gives you a simulated environment and it gives you a real-time environment. And I have seen people being very interested in those activities, and the same activity we now the same technology we are using to help patients to get better. So the software provides key concepts for motor learning. So basically there can be manipulation of frequency, intensity, repetition, and the task-oriented training. So virtual reality incorporates various theories of motor learning, and it provides the use of augmented feedback on performance that is provided immediately following a performance based on results. So immediately that talks about the knowledge of results and the knowledge of performance. Like however the patient is performing that activity, immediately he gets a feedback for it. So this is one example of virtual reality that is being used for upper extremity. So in upper extremity, various activities can be performed, for example, reaching or holding a task, which can be used for range of motion, improving range of motion, or for improving coordination, or for improving the strength. So this is one example of virtual reality for lower extremity. So this is one example. So in this image, we can see the person playing football or soccer. So the virtual reality can help in lower extremity as well for improving the balance, for improving gait, and for improving the lower extremity coordination and weight bearing. So we will now talk about a study that was performed in the year 2019 to assess the impact of virtual reality technology on multidimensional therapy with patients with acute stroke. So in this study, there were 100 patients with acute stroke, and acute stroke that is onset within 7 days, and they were divided into two groups. So the first group received virtual reality plus conventional therapy, and the other group received conventional therapy alone. So while the intervention group received 40 minutes conventional therapy and plus 20 minutes of virtual reality program. And the outcome measures used were NIHSS and MRS. So the conventional therapy performed activities such as range of motion exercises, fine motor training, strengthening, and cognition rehabilitation. And in addition to that, the intervention therapy also performed virtual reality in 4 programs, where the first program had reaching task for improving the range of motion and coordination. The second program had tracing tasks, so they basically had to trace an airplane, which helps them in the strengthening and range of motion of the upper extremity. The third program was the Kung Fu Soccer, which aimed at strengthening the lower extremity exercises and balance training and trunk stabilization. And the final task was cognition rehabilitation. So they had to perform various basic mathematical calculations or serial number arrangement according to values or color discrimination. And in the results, they found that the group that received both virtual reality and conventional therapy, they had significant improvement in NIHSS and MRS, and also showed better improvement of symptom severity functional outcomes and reduced medical cost, with higher proportion of functional independence. So the study concluded that combination of virtual reality along with traditional therapy could be more effective for neurorehabilitation than conventional therapy alone. So the third technique that we are going to talk about is robotic assisted therapy and how it is based on neuroplasticity, or how it helps in neuroplasticity. So robotic technology, it has remarkably developed in the recent years, and we will define robot as a reprogrammable multifunctional manipulator, which is designed to move a material or a part through variable programmed motions to complete a task. So we basically use this technique in the rehabilitation. So the rehabilitation robots could be of two types: therapeutic robots and assistive robots. So in the therapeutic robots, they provide task-specific training, and the assistive robots help in compensation for the lost function. So the most commonly found robotic rehabilitation is with the use of exoskeleton. So this is a type of robotic device where the axes are aligned with the anatomical axis of the wearer. So there is less amount of compensation, any amount of compensation or malalignment of the posture or movement that gets minimized. But the the drawback of this technique is the construction, because that is more complex and thus it is more expensive. So there's a study performed in the year 2016 with the aim to provide a overview of neuroplasticity, and the study mentioned about the strategies that improve neuroplasticity, and the robotic devices have been used as training tools to promote neuroplasticity. So that was a summarized study. The other study was performed in the year 2019. I have quoted the studies. If the viewers would want to read more about the study, they can find these studies. So in year 2019, the study was performed to assess the wearable exoskeleton could get higher gait performance than the conventional overground gait training. So the study had 40 patients with stroke. 20 patients underwent exoskeleton gait training for 45 minutes per section for 5 times a week. And in addition to it, overground gait therapy, while the other 20 patients only performed overground gait therapy. So this is one image of the exoskeleton. So basically, the backpack at the back that actually consists the battery that is required for the functioning of the exoskeleton. And the results showed that the group that performed both the conventional therapy and robotic assisted overground training that had improvement in the 10-meter walk test, corticospinal excitability in the affected side, sensory motor integration on the affected side, and overall gait quality with improved hip, knee, muscle activation, and frontoparietal effective connectivity. So this knowledge may be useful for planning highly patient-tailored gait rehabilitation programs. Now we talk about mirror therapy. So it is a very cost-effective technique that is again based on the principles of neuroplasticity. So as you can see in the image, what we do is the affected side of the patient or the affected side, for example, let's consider the upper extremity first. So the affected upper extremity is hidden behind a mirror, and the unaffected upper extremity that gets reflected in the mirror, and that gives a perception of the affected lower upper extremity that looks exactly like the affected upper extremity. And when patient performs movement of this unaffected upper extremity, that exactly resembles the movement of the affected upper extremity as well. So that's how it is tricking the brain to think or perceive the movement to be of the affected extremity rather than the unaffected. So it has various types. It can be static mirror therapy, it can be dynamic mirror therapy, it can be task dependent mirror therapy. So in the static one, we don't really expect the patient to perform that movement simultaneously on the affected hand. However, in the dynamic mirror therapy, we do expect the patient to perform the same, perform the activity on the affected side as well. And in task-dependent mirror therapy, we expect the patient to perform movements of the unaffected extremity, but they should be task-dependent. That is, they should be performing some task. So mirror therapy has been shown beneficial for phantom limb sensation, for stroke, for complex region pain syndrome, for various lower motor neuron conditions. So in fact, there is evidence that talks about use of mirror therapy in trigeminal neuralgia, in patient with median nerve injury, in patient with foot drop, and it also talks about the effect of mirror therapy in certain other lower motor neuron conditions. And it has also been shown effective for lower extremity. So for lower extremity, there can be a mirror box that that is kept in such a way that the unaffected lower extremity gets reflected in the mirror. Or it could be simply a mirror too. So now how does this technique work? So there are certain neurons in our brain which are present in the somatosensory cortices, and they are also called as mirror neurons. Now, what is the function of this mirror neurons? That is, they are active not only during performing certain activity, but they are also active even by looking at that activity. So that's how we are tricking the brain to think that the activity is being performed on the affected extremity, and that's how the mirror neurons work and help with the neuroplasticity. Apart from mirror therapy, there are certain other techniques such as action observation technique or motor imagery that are based on the same principles and mechanism of mirror neurons. So there's this study performed to see the neuroplasticity after mirror imagery. So this group had so this study had two groups with 13 patients in each group, and they performed standardized fine motor tasks using picks and marbles for 20 minutes per day for 4 days. And they performed the same activity with a mirror. So that is called as mirror training group, and the other group performed control training. The number of items moved by each hand was tested after each training session, and functional MRI was acquired before and after the training procedure to investigate the effects of mirror therapy. They found the hand performance test of the trained right hand did not differ between the two groups. The untrained left hand improved significantly more in the mirror group as compared to the conventional group. So there are many other studies in the literature that talks about the improvement of or the effects of mirror therapy. We will now talk about the other technique that is also called as functional electrical stimulation. So you must all be aware about the diagnostic muscle stimulator. So that basically helps you in electrical stimulation of, or you must be aware of neuromuscular electrical stimulation. So functional electrical stimulation is much similar to neuromuscular electrical stimulation. That is, it produces movement, or it produces certain muscle contraction in otherwise paralyzed limbs. The only difference between NMES and FES is the FES helps you perform some functional activity rather than just the movement. So what does FES do? So as you can see, certain electrodes kept over the attached over the dorsal aspect of the arm and the forearm, and those electrodes that actually provide low energy electrical impulses to generate body movement in the individuals. So they generate muscle contraction in otherwise paralyzed limbs to produce functions such as grasping. It can be used in the lower extremity while walking, or for bladder voiding, and in cases of neurogenic bladder, and in standing. So it helps you basically generate a desired function. The objective of functional electrical stimulation is to restore the voluntary function and not have lifelong dependency on functional electrical stimulation. So it is a very short-term intervention to help the central nervous system to relearn to how to execute the impaired functions. Now, how does it really work? So in neurons, the information is coded and transmitted as action potentials. So when we provide electrical stimulation, we are actually artificially eliciting this action potential by inducing the electrical charge. So this will have or help to regain or have the memory of that performed task, and that is how it is going to help in cortical remapping and thus in neuroplasticity. So there was a study performed in the year 2011 with the aim to study the role of neuroplasticity in the therapy-induced enhancement of the hand motor function, which was performed on 20 patients with hemiparesis. in chronic stage. So the subjects were randomized in two groups, that is functional electrical therapy, and the other one was conventional therapy group. So they saw the faster corticospinal conduction and newly found muscular responses observed in the paretic upper limb in the FES group, but they did not find the same results in the conventional group after intervention. And functional electrical stimulation or therapy of the paretic upper limb, they summarize that can help or enhance the neuroplasticity observed as the corticospinal facilitation in stroke subjects. So here we come to the end of our second part of the topic neuroplasticity in rehabilitation.
Thank you so much, ma'am. It was a really informative session, and it will really help to all the budding physiotherapists to use this knowledge in their clinical rehabilitation. Also, I would like to give a vote of thanks. Firstly, I would like to thank Dr. Manisha Sangvi ma'am, Dr. Parag Sancheti sir for giving us this opportunity. I would like to thank Dr. Apurva Shimpi sir for always supporting us. I would like to thank the technical team. Without them, as it would not have been without them possible at all. Thank you, Dr. Tushar sir. Thank you to all our viewers as well. Thank you so much.